the Senate Health and Welfare Committee to order at this time. It's time for new pages, so I just wanted to invite, we'll have our secretary take a silent roll for us. And then committee, we have a new page. Well, we have 3 of them in here, actually. We'll have them all introduce themselves real quick. But our main page is Jonathan Richardson, and we'd like you to go to the podium. Introduce yourself, and then tell us a little bit about you. Welcome to the committee.
Thank you, Madam Chair. I am Jonathan Richardson. I live in Shelley, Idaho. I've lived there my entire life, and I do concrete. I've been doing it the past 4 years. And yeah, and my school comes here each year from Idaho Falls, Idaho. And they, for the past, actually I've been here, this is my 4th year, it would be. And each year, some of our students go as pages, and that's how I got word about the job. And I want to thank you for sponsoring me. Thank you.
We didn't scare you off then.
No, you did not scare us.
If you've been here that many times. Committee. Any questions that you'd like to ask Jonathan at this time? Senator Winthrop, you don't have a question? No? Okay.
Oh, no, I see.
Okay, Senator Blaylock.
Thank you, Madam Chair. I'm curious about the concrete. What type of stuff do you pour?
Okay, so
Jonathan?
Oh, sorry, Mrs. Madam. Thank you, Chair. I have, for the past 4 years, my first 2 years was mostly just foundations for residential and commercial jobs. And then recently, the past couple of years, I've been doing more flat work. And that also comes with the pay raise, so thank you. Yeah.
Senator Shippey.
Thank you, Madam Chair. I guess my question is, how many yards of concrete have you poured out in one day? What was the max?
Jonathan.
Madam Chair, thank you. About 400. Yeah.
Okay.
So from
my max was 250, so.
yeah. So from about 2 a.m. to 8 p.m.
Wow. Wow, that's a long time. Okay, committee, well, thank you so much.
Thank you.
I'd like you other guys to introduce yourself, please. So, do you want to stand up? Thank you.
Hi, thank you, Madam Chair. My name is Louis Reale. I just moved here from Hawaii, actually, so this June. I'm very grateful to be a Senate page, and I'm grateful for the opportunity. I have a very big passion for politics and hope to be a senator one day myself. So I like to keep busy. I'm a busybody. I play a sport every season. I'm from Sandpoint, Idaho, but I was just in Boise for swim state. So Sandpoint we're state champs. So very proud to be able to say that. Yeah, if you guys have any questions, please let me know.
Thank you. Senator Winthrop.
Thank you, Senator. And I've heard it Louis, I've heard it Louis.
It's Louis, like Louis Vuitton is what I tell people because it usually helps it click.
Thank you, Madam Chair, and Louis. Yeah, it's nice to have you. Like Hawaii, tell me about Hawaii and why come to Idaho from Hawaii?
Yeah,
Louis.
definitely a big culture shock for sure. It was mostly up to my parents. It was their decision. And I am still a senior in high school, so I didn't have much say in the matter. Yeah.
All right. Thank you.
Yeah.
Thank you for being in committee with us.
Thank you, Madam Chair.
Okay. We'll have you come up.
Hi, thank you, Madam Chair. My name is Olivia. I'm from Boise, Idaho, but for the first 14 years of my life, I lived in Westport, Connecticut, so I'm a long way from home. Something interesting about me is that I have dual citizenship in the Netherlands from my mother, and I'm hoping to pursue international law or maybe be a JAG lawyer because I have some influence from the military in my family. Some hobbies of mine, I'm a ballerina, I do horse riding, I like to shoot, and I like politics. It's a really big passion of mine. I'm taking AP Gov this year and it's really interesting, but I thought it would be a lot more fun to do it in person. So I love politics, but I'm also really into fashion. I'm really into learning languages. And so I'm just kind of trying to go into the world of politics, but kind of put my own little twist on it.
What languages are you learning?
So from my mother, I speak Dutch, and by extension, I can speak Afrikaans. And I've been learning French for 6 years.
Thank you. Thank you. Man, we've got some quality pages here today. Whoa. Okay, thank you. I know. I feel like underqualified sitting here, right? Okay, committee. All right, first we have up on our agenda, we have the minutes from February 3rd. Senator Harris.
Madam Chair, I've read the minutes of February 3rd, 2026. I found them to be riveting. I move their approval.
Second.
It's been moved by Senator Harris, seconded by Senator Bierke to approve the minutes of February 3rd. All those in favor, say aye.
Aye.
Okay, thank you. All right, our next agenda item is House Bill 558. Representative Tanner, welcome to committee.
Thank you, Madam Co-Chair, or Madam Chair, and members of the committee. My name is Josh Tanner. I'm a representative from District 14. Like the good chairman stated, the House Bill 558. This deals with the survivor benefits for foster youth. And really what we're trying to do here, and this what's already actually done within Idaho, this was an executive order that actually made it to where we no longer divert Social Security benefits from foster youth, the survivors' benefits from their families, from their parents that passed away, to use as overhead for government and bureaucrats. We want to make sure that those funds actually stay with the child as they go on and transition out of foster care, and that gives them a means to actually go off on their own and instead of being continuously dependent upon the state, gives them kind of what their parents, this is their last thing that a lot of times, a lot of these kids, it's the last thing that their parents gave them was this survivor benefit. But we just really want to make sure that since this is already an executive order, this is just codified into law to make sure that we as Idaho make sure we are protecting these foster youth that their parents had passed away. And just kind of point out, this has been a big push from the Trump administration as well to make sure that states actually are pushing back and working away from that. And I believe currently we're down to 36 states left that are still doing it. Idaho is not one of them because we have an executive order. This just kind of codifies it. But with that, I stand for any questions. If not, I turned over to my to be the House or the Senate sponsor, which would be Senator Nichols.
Senator Nichols, did you have some comments?
Thank you, Madam Chair and Committee. For the record, Senator Tammy Nichols, District 10. I don't have a whole lot to add. We know that this has been an issue, and it's pretty much just codifying what we really need to do. And again, like Senator Tanner or Representative Tanner was saying, that this is kind of one of the last things that parents can leave to their kids to be able to utilize. And we know coming out of the foster care system is not easy. And so the more that we can do to help our kids get out of that system and be able to get into regular life, the better. So I don't really have too much more to add, though, but we will stand for questions.
Questions? Senator Kaiser?
Thank you, Madam Chair. Representative Tanner, just to confirm, voting for this bill will allow earned benefits to go to orphans, and a no vote on this would basically allow the government to confiscate the earned benefits to pay for overhead?
Representative Tanner.
Thank you, Madam Chair and Senator Kaiser. In a sense, yes, except for we do have the executive order already out there that is currently doing this. There is a lot of confusion out there on this, on different parts of how it's funding. So one of the things that we are trying to make sure is these are just dealing with foster youth. There is another segment that a lot of people get confused with, and this has to deal with a lot of elderly people when they want to go into some of the Medicaid services or Medicare services, that they can actually give up their Social Security benefits in exchange for getting this other benefit. That has nothing to do with this bill. And that was a confusing aspect for people that were somewhat getting lost, that kind of started digging into this. This only deals with the foster care youth. And with the adults, the elderly, they make that decision to give up that right. These orphans do not get that decision. The states were generally, and there's currently 36 states out there, and it sounds like there's a couple more that are coming off in the next couple weeks. So they're hoping by the time we hit the end of session that they're going to be back down to about 30 states. They're going to continue to work on it for the next several years to get it to where hopefully we get to where we're at zero, to where 0 states are stealing orphans' benefits to offset bureaucratic overages and their costs. So,
Thank you for that.
Senator Blaylock.
Thank you, Madam Chair. Just a question about the fiscal note. Says that there's no increase or decrease in revenue. And then later it says the Department of Health and Welfare already ended this action and based its budget submission around it. When did they end? I guess, yeah, when did they end this action?
Representative Tanner.
thank you, Madam Chairman and Senator Blaylock. So this was last year. So last year, this was an executive order that was actually done. So the current budget that actually had gone out, it already had been adjusted for that fiscal note. So yeah, last year it was already out. This year it's already out as well. But that was roughly, it was hard to figure out the exact number, but that was kind of why there's a range there, is that was the range.
Follow up.
Thank you, Madam Chair. Yeah, I've never seen a fiscal note like this before. This is interesting, because it says that there's no increase or decrease from last year, but during last year, they took this program away and potentially it's diverting $250,000 to $500,000 of Social Security survivor benefits. Wouldn't that have to be reflected in the budget as revenue that's not coming in now? Is that right?
Representative Tanner.
Yeah, thank you, Madam Chairman and Senator Blaylock. So it doesn't actually show up on the budget because it's now built within their budget. So this was an executive order that was done that removed us from taking those Social Security benefits, and then it was built back in. So these were just a foster youth aspect for those kids that Social Security money was coming back in is no longer being taken from that.
Thank you.
So yes, it is not there anymore.
Senator Zeiderfeld.
Thank you, Madam Chair and Representative Tanner. So from my understanding, I want to make sure I'm clear. So the state is now going to oversee and help the foster children receive their benefits, help them file and all of that. I want to make sure I'm clear before I ask my question on that.
Representative Tanner.
Yeah, thank you, Madam Chairman. Senator Zeiderfeld. So no, they're not going to help them out at all. They're just no longer able to take their money. That money goes and it's going to stay with them until they turn 18, where they can actually go off on their own and transition away from state. I mean, realistically, their custody is at the state at that point in time, and making sure that those dollars actually stay with them when they go to become adults, that their parents that had passed away and left them this survivor's benefit, that they can actually take that and move off. And if they're going to college or trying to get a house or trying to just get off on their own and away from the state's programs, they have the means now to be able to do that.
Follow up.
Okay, thank you for that. So they right now, so then our children are getting like Medicaid benefits and stuff like this. This will be in addition to that. They'll be getting that Medicaid cost along with the Social Security from their parents.
Representative Tanner.
Yeah, thank you, Chairman and Senators Zeiderfeld. So yes, they automatically qualified either way and it depends on the kid. And there are some kids that come in that have disabilities within it, and they're under a whole different program as well. Either way, you're trying to protect those Social Security benefits to make sure that those ones are the ones that are protected. That dollar amount that their parents were paying into were protected. So, I mean, I know your kids aren't young, but your kids, for your grandkids that would come along, if for some reason they were to die and there was no one else to take their kids, those kids. Now, again, one of the things we did last year as well is we really worked on making sure that those foster youth actually stayed out of the foster care system and stayed with either grandparents or some other means, stay with direct family in general. And we made that a priority last year. But in general, we had an issue with foster care system within our state we had a very low rate of the amount of foster kids that were going in versus the people that were willing to take on foster kids in general. And that was one of the things we actually had done in JFAC this last year is, well, there was a bill that actually went out, but there was, we put some language around to making sure that they had that 1-to-1 ratio, that they had to meet that ratio. Otherwise, the additional support that we gave health and welfare for them to get there would go away automatically if they weren't unable to get there. They have gotten there. They've actually exceeded it. They've been able to maintain and actually stay a little bit above that, which is better than almost every other state out there. I mean, it was a huge feat in a very short period of time for us to be able to get to that. But within that, there's a lot of these foster kids that their parents do pass away. And we're not talking about the kids that are, their parents are in prison or something like that get caught up in this system. But we're talking about the kids that's a survivor benefit, the kids that their parents actually passed away, and we want to make sure that we give that their parents that last bit of money that they gave them goes for something when they actually get away from that state system. Because what we're seeing as well is a lot of times the kids don't have any means once they get done with the foster care system. They don't have any parents out there. They don't have a lot of the family out there and no means to do it. And then they stay further upon government systems throughout. This will actually help them, give them a position to be able to transition on beyond that.
And just one last follow-up, and I know it might be more of a comment, but didn't we change the age from 18 to 23, so they will be receiving these benefits up to the age of 23?
Representative Tanner.
Yes, thank you, Chairman and Senator Zeiderfeld. That is correct. So we allowed them to, this last year, a bill went out that allowed them to actually go up to the age of 23 with some of the benefits on there to try to help transition them away.
Senator Shippey.
Thank you, Madam Chair and Representative Tanner. I just wanted to maybe see if you could speak to the benefits themselves. I guess what are the origin of these benefits? Maybe you could just provide a little clarity on that. Are they, just talk to that a little bit. What these benefits are, where that money originates from.
Representative Tanner.
Yeah, thank you, Madam Chairman and Senator Shippey. So it's your Social Security money. So same as when you probably have a job. I mean, even this job for you, you're paying into Social Security, and that's the Social Security money. So that's a federal Social Security. The Social Security money is withheld within the feds, and it's just depends if we want to use it to actually use for these kids to be to offset our cost as a state to take them in the foster care system, or do we? Because now they're custody of the state. State actually. In a sense, I mean, they're the parents. It was one of the things that when Director Alex Adams when he was in that role, one of the things I actually gave him was a trophy that said, greatest parent for the most kids in the state of Idaho, because being the director of health and welfare is not just a role of dealing with all the other programs. You are now the custodian of the kids themselves. And you've got a mass amount of these kids that this happens to. I mean, whether it's a car accident or anything else, this has become a bigger issue across this country, and we want to make sure that that survivor benefit that any kid would get is not being taken by the state. So if the parents were the ones that had to adopt the kid, or a cousin or another sibling were to adopt those kids, that survivor benefit would stay intact. It's just when the state takes over, we take that money. And that's what we're trying to make sure that we're protecting, that money, to make sure when they go further in there to their lives, that they have that survivor's benefit to be able to get on to the next stage of their life.
Senator Bierke.
Madam Chair, is a motion in order?
Yes. We don't have anybody signed up to testify, so thank you.
Yep.
Motion is in order.
Thank you, Madam Chair. I move to send House 558 to the floor with a due pass recommendation.
Second.
So moved by Senator Bierke, seconded by Senator Kaiser, to send House Bill 558 to the floor with a due pass recommendation. Do we have any more discussion? Senator Lenny.
Yeah, thank you, Madam Chair. I think it's a good bill, good practice. I don't think state custody erases a child's entitlement, and I don't think the state should be able to raid a foster kid's bank account simply because we might be spending money on them in other areas. So, I mean, unless someone can convince me otherwise, I'm going to be a yes on this bill. Thank you.
Okay. No more comments? All those in favor of the motion to send House Bill 558 to the floor with a due pass recommendation, say aye. Aye. Any opposed?
Nay.
Okay. Would you like to be recorded? Yes, please. Thank you. Okay. All right. Thank you, committee. Thank you. Next up, we have House Bill 528. Senator Nichols.
Thank you, Madam Chair and committee. For the record, Senator Tammy Nichols from District 10, and I'm presenting House Bill 528. My sponsor from the House is also here, and I'll be turning over the time to him as well so he can talk about some of the logistics of this bill. But this bill is about ensuring Idaho patients can access a medical option that is already permitted under federal law. Directed and autologous blood donations are federally allowed and already processed through licensed blood establishments under physician orders. Several states, including Florida, Kentucky, and Indiana, have clarified this in statute, and others such as Utah and Tennessee have recently advanced similar legislation. Idaho would simply be aligning its law with that of existing framework. However, we have had Idaho doctors and patients report that when they have attempted to pursue a directed or autologous donation for a scheduled procedure, they were turned away or encountered roadblocks. When something is federally allowed and medically appropriate, but patients cannot reliably access it, that is a gap worth addressing. This bill does not change safety standards. It does not override medical judgment. It does not apply in emergencies or when donations would be harmful. It simply ensures that a facility may not prohibit a patient from pursuing this option when it can be done safely and in compliance with federal requirements. So this is about clarity, alignment with federal law, and access for Idaho patients. And with that, Madam Chair and committee, I'd like to turn over some time to Representative Bruce. Thank you.
Thank you. Welcome to committee, Representative Bruce. Please identify yourself, and then the time is yours.
Representative Chris Bruce, District 23, which is South Canyon, South Ada, and all of Oahe. And that was actually pretty good. She kind of got all of it out there. I can just speak to some of the things in the bill. You know, I came to this committee last year and had a different bill that had a lot of hoops that we jumped through. I went back and looked at some of the feedback that I got from your committee and from other folks, and then looked at this as a different option. Since this is already federally legal, like you said, we're just clarifying that Idaho accepts that as well. If you look at the bill, there are still provisions that you can be turned away to do this if it's detrimental to the donor or to the patient, if insufficient time exists, or if it's an emergency. What we heard in the House committee is that there's still ways that folks can be denied. This does protect doctors, and that also the person donating will absorb all that cost. We have folks here who can testify to their experience, and so I would ask that you pass any questions on to them because they can tell you what they've dealt with. My thought is that if it's federally legal, Idaho should also conform to that. That way folks are not having to leave the state to get this done.
Thank you. Do we have any questions? We do have 3 expert witnesses that Representative Nichols has asked if they could testify. So at this time, I'll let them in.
Thank you, Chairman.
Okay, first, we have Liz James by video.
Can you hear me okay?
I can.
Okay,
Welcome
thank
to
you.
committee.
Thank you, Madam
Please-
Chair.
Please identify
Madam
yourself.
Chair.
And then the time is yours.
Madam Chair and committee, My name is Liz James. I'm a pharmacist and founder of the nationwide nonprofit Blessed by His Blood, and I speak on behalf of House Bill 528 and represent Blessed by His Blood cooperative members. Despite the assurances issued by the blood industry representatives that blood for transfusion is safe, statistically, these reassurances are no longer simply taken at face value by the general public. According to data from 2022, public confidence in the medical industry has dropped to below 40%. That 60% plus that lost confidence in the medical industry include those within your constituency. We have been helping Idahoans leave the state to get medical care since 2023 when they've been denied direct donor blood. I'd like to share a little history. 40 years ago, the blood industry made the purposeful choice to cover up the contamination of the transfused blood supply. Well-documented congressional hearings in the 1990s confirmed the complicit actions of the blood banks, which cost thousands of people their lives. In the early 1990s, James McPherson, who was the director of what is now America's Blood Centers and the Red Cross's regulatory affairs head, would admit that they had made a mistake, and I quote from him, "When we were touting the risk as 1 in a million, we hadn't a clue. It was a stupid thing to say, but we were afraid. We had this desire to reassure the public, and we should have been honest and said, we really don't know what's going on." That's kind of what we have going on now. Today, one of the blood industry arguments are that direct donor blood raises immunologic risks if the direct donor is a blood relative. While we agree that this can be problematic, the reality is that direct blood donors are often friends, acquaintances, non-biologically related relatives, and member of like-minded organizations, all of whom would no more raise immunologic risk than that of an anonymous donor. 5 months ago, renowned oncologist Dr. Wafiq El-Diri and Dr. Charlotte Cooper-Wasser presented to HHS's ACIP committee regarding the health implications of vaccine mRNA confirmed to be found in blood and tissue more than 2 years after the shot had been issued. Their presentation concluded with the number one recommendation: proactive and modernized safety surveillance programs, including blood and tissue-based monitoring. There is confirmed risk of DNA contamination, genomic integration into the tissue of recipients, and cancer mechanisms of action, and more. These science-backed concerns are serious enough to warrant caution, and our federal HHS chose to respond to these ACIP-backed concerns in a way that protects citizens. Today, we ask that you do the same. In summary, passing HB 528 would be an important step in reclaiming constituency trust that patient autonomy, which is the cornerstone of clinical ethics, will be respected as it pertains to direct donor blood. It will also ensure the medical revenue currently being lost to out-of-state care is restored. At least 17 states are currently working on similar legislation. This is also on our federal HHS's radar, and it's not an issue that's going to go away. On the contrary, it's only growing in size and scope. History has a habit of repeating itself unless we learn from it. Please protect your constituents' right to choose direct donor blood. Thank you so much, and I'm happy to take questions.
Okay, committee. Do we have any questions from the committee? Seeing none, thank you for being with us today. We appreciate it.
Thank you so much.
Okay, next we have Sierra Ham video. Welcome to committee. Can you hear us okay?
Yes, I hear you great. Thank you so much.
Okay, thank you.
My name is Sierra Ham. It's a pleasure to be with you today in promotion of this bill. I'm a registered nurse. I'm a mother of 4, and I've had an emergency blood transfusion before. I'm here representing the reconciliation, which offers the enhancement of blood transfusion services through education and private donor coordination. I've administered blood transfusions many times as a nurse in clinical practice in the hospital. And after planning the birth of my 4th baby, I personally chose to use the 40-year-long established direct blood donation pathway. And since then, I became the person in my community that helps others who have decided that they want more options for their health than the blood on the shelf. And I've been helping people who simply want to have a voice in the kind of blood and care that they are receiving. And I respectfully ask that you support 528 because it protects a patient's fundamental American right to bodily autonomy and to choice, which allows people with their doctors to make the same decisions about the blood that they receive as they would for any other medication. Opponents raise main concerns. First, that directed donation is less safe, and second, that it's too complicated to implement. And I'd like to address both now. First, let's talk safety. It's really important to me as a nurse. And the most comprehensive study ever done on this subject was conducted by Dorsey et al. And of the American Red Cross itself. It's published in the Journal of Transfusion Medicine, and they looked at 40 million donations, 70,000 of which were direct donations. And they were looking for positivity markers of the donors for the real bad stuff, HIV, Hep B, Hep C, HTLV. And at first glance, it looked as though the direct donor group had an increased risk of Hep C. But once they controlled for variables such as age, sex, race, but most importantly, when they controlled for first time versus repeat donor status, that difference went away. So after adjustment for that, they found direct donors were no more likely to test positive for HIV. Directed donors were no more likely to test positive for Hep B. They were no more likely to test positive for HTLV. And most importantly, directed donors were actually 30% less likely to test positive for Hep C. The Red Cross itself concluded that the main predictor of infection of the donor was that first-time donation status. In other words, these are people who didn't know that they had a communicable disease. And actually, this screening probably saved a lot of people's lives as an early detection for them and to stop the spread of this, whatever disease it was. This is critical because this paper is used over and over to claim that it's less safe and that if you just read the article and evaluate it, it's not saying that at all. Remember that any blood that is screened positively for an infection from the donor is discarded. We don't administer that to a patient. First-time donors were found to have dramatically higher rates, and that's regardless if it was from a public or a private donor. Families who choose direct donation almost always recruit young, healthy people that they know, and many of them become repeat donors. And that data shows that it's at least as safe as the public blood supply. Secondly, let's talk complexity. Hospitals already operate as contracted with a hospital. So if you want to get a directed donation, you have to find out what blood bank is working with that hospital already. So they already have a system to get that blood to that specific hospital. Everything is barcoded, labeled and tracked. It's a 2-person, 2 RN checkoff to administer blood. It's a pretty in-depth process. And I don't see, as a nurse at the bedside, how in the world this would add anything whatsoever, complexity-wise, at the bedside. There is plenty of room in coolers for blood because there's constantly a blood shortage. So this bill doesn't create a new system. It's just protecting a patient's rights to access one that already exists. Direct donation is not experimental. It's not unsafe. It's a long-established FDA-supported and created process. So please support 528, protect patient autonomy, and also maintain the same safety for all blood transfusion. Thank you.
Thank you. Do we have any questions? I see none. Thank you, Ms. Ham. Thank you for being with us. Okay, next committee, we have Clinton Ohlers. Hello.
Hello, can you hear me okay?
Yes, we can.
Okay, great. Well, I'm here a little large here, so I will just adjust that. So my name's Dr. Clinton Ohlers. I hold a PhD in history focused on history of science from the University of Pennsylvania, and I represent Safe Blood. And Safe Blood is an organization with over 60 members and growing in Idaho. We work with great hospitals, doctors, and blood banks around the country that facilitate directed autologous donations. Okay, these organizations do so often at little or no extra cost to the patient, and this is especially true when they add blood to the system from directed donors that might not have been needed for the original recipient, and then it is integrated into the general supply. And that's just a matter, whether that's done is a matter of state and health provider policy. Okay. Now, unfortunately, Idaho is not currently one of these states. And so without the protection for this previously controversial pair of patient freedoms, this is being denied arbitrarily in your state and causing real harms to patients. You know, for example, an Idaho man who had to travel 4 hours to Salt Lake City just to receive a surgery he needed where he would be allowed blood that he was comfortable with that was a safe FDA compliant match. We frequently hear that bills like this are unnecessary because, you know, these autologous and directed donations are allowed, or they're allowed when medically necessary. But let me assure you this is not the case. In many states, we have a great working relationship with the American Red Cross. However, it is not the National Red Cross that decides this policy, but the Red Cross director in the individual state. And the director in Idaho so far has refused to allow these types of donations. So Idahoans have to go elsewhere. And look, Idaho is not alone. The Ohio Red Cross is similar. In Washington, we had a family that had to travel all the way to Pennsylvania to get surgery for their little girl when she was denied safe matches from her parents. I recently spoke to a woman in Minnesota awaiting a bone marrow transplant. She had normally and regularly gotten directed donations, and then that was arbitrarily cut off. She had then had to travel to Florida. Now, when I spoke to her, she said to me, Clinton, I'm now too sick to travel, and I don't know what I'm going to do if my blood levels drop again and I need a transfusion. So this is, you know, real human plight here that is easily and inexpensively avoided. You know, about medical necessity, this is one that's regularly used to deny patient and doctor choice on the grounds that these types of donations are not the only alternative. Now, this is exactly what a heart surgery patient at Baylor St. Luke's in Texas faced. There, the blood bank was completely cooperative to facilitate these types of donations, but the patient reports he was denied blood from his wife, who was a universal donor, friends who were compatible matches, and even his own autologous donation on the grounds that they were, quote, not medically necessary. Another kind of misleading idea is that protecting these rights would increase wasted blood. You know, as I alluded to before, if the patient doesn't need the blood, it's a matter of, you know, provider policy and state law as to what happens to that blood. And so in many states, that blood is reused and they are very happy to receive it. You know, and I'm going to say that denying the rights for such reasons, you know, does result in really real harms physically, financially, psychologically, and emotionally. And it's not only parents who are, or patients, excuse me, who are avoiding, you know, first time or additional exposure to the mRNA vaccines, where we have seen adverse reactions occur in patients whose only exposure was through a blood transfusion. But it's also patients that are harmed who need, say, have beta thalassemia or sickle cell anemia that were really harmed when their donations are denied. And certainly, as long as we don't know how extensive the risk is, and that for some people it's not zero, I can't see how, in good conscience, you know, we cannot support the patient freedom to protect themselves as they and their doctors see fit. So I strongly urge you to pass SB 528. I think it's an excellent bill. Thank you.
Thank you. Do we have any questions from the committee? Seeing none, thank you for being with us today.
Thank you.
Okay, committee. Um, Okay, next we have James Elliott on video. Welcome, Mr. Elliott. Please identify yourself, and then the time is yours. We have a timer. Thank you.
Okay, sure. Good afternoon, Chairwoman Van Orden and members of the committee. My name is Dr. Cole Elliott, and I'm here to represent the American Red Cross and serve as medical director for Idaho. I oppose the bill since, as you've heard, autologous and directed donations are not against the law currently, and it sends a message to the community that the blood supply is unsafe. The Red Cross is a humanitarian organization with the mission of helping, and that extends to our blood operations with donor and patient safety a top priority. We take what the donors give us and help as many people as possible. A main benefit of directed donation is when a patient has a rare blood type and compatible blood could be difficult to locate. Directed donations are not safer than those from the volunteer donor community. There are risks with direct donations from family members, and they must be irradiated to prevent graft versus host disease. Hospital blood banks may not be set up to receive and release these donations, and this could in particular put a strain on smaller hospitals. Both donations create wastage when not transfused, and autologous donations cannot be given to anyone else per law. Unlike pharmaceuticals, blood cannot be synthetically produced. The healthcare system relies on the volunteer donors to maintain a safe and sufficient blood supply. Every 2 seconds in the United States, there is a need for a blood transfusion. However, with fewer people donating than any time in the past 20 years, we are experiencing blood shortages. And this can be compounded by storms and holidays. There's an ongoing strain on the blood supply, and diverting resources away from the volunteer donor community could further hinder our efforts. The bill states an emergency will be declared. If we are in an emergency, shouldn't we hear about patients with poor outcomes on a regular basis? I would also like to say that the Regional Red Cross Director does not block any of these donations in Idaho. That is not true. In conclusion, the bill sends a message that the current blood supply is not safe, and I must oppose the bill. Thank you for listening and the opportunity to speak today.
Committee, any questions? Senator Wintrow has a question.
Sure.
Thank you, Madam Chair and Dr. Elliott. Talk a little bit about some of the, I guess, the science behind the blood supply and its safety. Like how do we make sure it is safe, you know, as far as donors and transfusions and those kind of things?
And thank you
Mr.
for the
Elliott.
question. Well, we do have regulatory requirements for vital signs. For one, that's for your hematocrit or hemoglobin, that's the blood level. Also your pulse, blood pressure. There's a pretty lengthy questionnaire, can be over 40 questions, which ask if you're feeling okay, healthy, various medical conditions that you've had. For autologous donors, the restrictions are not as firm, so we may let them donate with a lower blood count. And that's one of the reasons autologous donor blood cannot be diverted to someone else in the hospital, even if they say it's okay. It's not the way that part works. But after it's collected, you have viral testing done for HIV, hepatitis, in particular syphilis. And so if any of those units test positive, of course, we're not going to be used. As was mentioned, those are tossed. Platelets now have pathogen reduction mechanism in them, so we can really take out any bacteria to make it much safer. Platelets are kept at room temperature, most of them, so they're more prone to have bacteria develop, whereas your other products are frozen and refrigerated, and that can decrease some things surviving. Does that help? I would like to mention one more thing. The latest numbers that I've seen on blood supply safety don't go into directed or autologous, but as one of the speakers mentioned, it looks at first-time donors versus repeat donors, and that's from the Canadian Blood Services. And what you will see, directed donors may not have ever donated before. Their family and friends are going to ask to donate. And so if you're a first-time donor, you're looking at twice as likely to test positive for HIV, 15 to 30 times more positive for hepatitis B or hepatitis C.
Okay, thank
That's
you.
some of the things I can think of.
Senator Wintrow, did you have another follow-up?
I appreciate that. No, it's good.
Okay, thank you. Thank you for being with us today. I see no more questions.
You're welcome. Thank you.
Okay, committee, next we have Shani McLaurin on video. Welcome to committee. Could you hear us?
Good afternoon. Can you hear me now?
Yes, please identify yourself and then the time is yours.
Thank you, Madam Chair, members of the committee. Thank you for your time. My name is Shani McLaren. I'm a private citizen in District 9. And I support House Bill 528 because of my background in healthcare education. I worked in healthcare for 23 years in community as well as clinical education. It is my responsibility as an educator to provide non-biased information so the patient can make informed decisions and informed consent before treatment. And the state of Idaho has made great strides to legally protect its citizens and their decisions surrounding their medical freedom. When a patient's facing an elective surgery, there is already a streamlined and comprehensive plan in place, and that allows the patient to store their blood for use for their upcoming surgery. Legislation systematically promotes autologous and direct blood donations with a physician's order and improves choices and desired outcomes for patients. I'm willing to pay a fee and a membership for the freedom of choice with this method of blood collection, storage, and distribution. Autologous and direct donor blood donations are important tools in medical scenarios, such as when a patient has rare antibodies. And widespread shifts will definitely happen when we are able to expand the donor pool with respect to Bill 528. And allows companies and using other donation companies for their freedom of choice. It's another example of medical freedom and making decisions with regards to bodily autonomy, and it's not illegal. Position papers and control trials and statements made by experts in the field of medicine have powerful influence over for-profit companies. We're just simply asking for that freedom to be exercised. And the choice to choose. The bill would allow patients to gratefully enjoy the medical freedoms we've worked hard for. And I appreciate your consideration in this bill. Thank you.
Thank you. Do we have any questions? Seeing none, thank you. Thank you for being with us. Okay, next we have Sarah Bacon. Welcome to committee. Please identify yourself and then the time is yours.
Thank you. Dear Madam Chair, Van Orden and members of the committee, my name is Sarah Bacon. I'm a resident of Kimberly, Idaho. I'm also an elected precinct committeeman for Precinct 3 in Kimberly, but I'm testifying on behalf of my own views. Today, I'm just here to say that I strongly support the passage of HB 528. I believe it is prudent for the state of Idaho to codify the right and ability for individuals to use direct donor blood, consistent with our values of medical freedom of choice and individual rights and responsibilities. HB 528 ensures that individuals seeking direct donor blood are not turned away, refused, or caught in a circle of red tape, unable to get the services that they need. There may be a variety of reasons, whether it be medical, personal, or religious, that a person may seek direct donor blood, and every individual deserves the right to direct their medical care to the furthest extent possible, and access to direct donor blood is no different. I ask you to please vote yes to pass this bill out of committee and take one step forward in favor of upholding the highest standards of patient care, transparency, and choice in Idaho. Thank you for your time.
Thank you. Do we have any questions? Seeing none. Thank you. Thank you for being with
Thank
us. Okay, next committee, we have Dharma Nichols. Welcome.
Thank you.
Please identify yourself, then the time is yours.
Thank you, Madam Chair, and members of the Senate Committee. My name is Dharma Nichols, and I'm here representing the American Red Cross. I am the Biomedical Regional Donor Services Executive in Idaho, Montana, and East Oregon. And I live and am based out of beautiful Boise. And I'm here today asking you to vote no on 528. The life-saving mission of blood services within the mission of the Red Cross to alleviate human suffering is to make sure that we have blood available whenever it is needed. The safety of the blood supply and the safety of Idaho's blood donors and recipients is our top priority. We already have an established process in place for directed and autologous blood donations. When the order comes in from the physician, we fill it. The process is safe for both the donor and the recipient, and this legislation will not change that. Not all people are eligible to donate blood. The donors will still need to qualify to donate blood, again, for the safety of the donor and for the safety of the recipient. Beyond needing to be a compatible blood type between the donor and the recipient, the donor needs to be healthy and meet additional requirements. Currently, only about 60% of the population is eligible to donate blood. And now, in addition to eligibility, donors are commonly deferred for many reasons. Sometimes it's low iron or taking certain common medications, blood pressure, injuries, international travel. There's really quite a lot of reasons that somebody could be deferred for donating, for being eligible to donate blood. And this legislation, again, won't change any of that. My concern is that it will create a lot of confusion and questions around the entire process for blood recipients and everyone involved. There would be an assumption that the current very safe blood supply is somehow inferior to a directed donation. And that's not the case. There's been testimony, a lot of testimony around that. And I think it's safe to say that at least they're the same safety.
Thank you, Ms. Nichols.
Oh, is my time up?
is up.
I'm sorry.
Thank you. Any questions? Senator Blaylock?
I do have a question. Thank you, Madam Chair. Is it Dharma? Is that right?
Yes.
I hear all the time that we have a blood supply shortage, and we're always trying to have blood drives and things. In the case of a non-emergency, so if I'm planning a surgery and I know there might be a risk that something could happen and I might need a blood transfusion, could something like this, like a program like this, being more robust in the state, actually help increase blood supply? Like if I send out a text to all of my friends and family, like, hey, I have a surgery in 2 weeks, go donate this blood, and so it's like I'm going to the surgery with my own preferred blood supply. I have no idea. I'm just saying, like, could this actually work to help increase the blood donations in the state?
Ms. Nichols.
Madam Chair, thank you, Senator Blaylock. Generally, I guess anything is possible, but that's generally not what we see. Those resources would be diverted away from filling the general blood supply and be diverted towards filling those directed donations. And so, those go in a separate pool, so to speak.
Follow up? Oh, okay.
Follow up, Madam Chair.
Senator.
I have a follow up.
Oh, Senator Harris.
Thank you, Madam Chair. Ms. Nichols, so can't that blood be used somewhere else, or does it have to be saved forever?
Ms. Nichols.
Chair, Senator Harris. It depends on how it's directed currently. So currently, no, most of those donations are wasted and if they're not used, then they are discarded. Additionally, we had testimony in the House around that most all directed and autologous donations, if not used, are discarded from the doctors, not from me.
Senator Shippey.
Thank you, Madam Chair, and Ms. Nichols. So I guess it's a kind of a follow-up on some of the questions that have been asked by the other senators. it was stated that if this bill were to pass, the already shortage in supply would be exacerbated. But it seems like it would be bringing in additional donors that maybe currently aren't donating. I think of other ways that, somebody is a common donor for a political campaign in general, but others aren't motivated to until it's a cause that they really care about or a person they really care about. And so there might be people that will never donate in blood drives, but would donate if it's a family member, a friend, et cetera. And so I guess the question is, the shortage right now, is it because we don't have the ability to take enough donations and the people are lining up and we just can't take those? Or is it just the people aren't lining up? I guess that's the kind of the question here, because if it's we don't have enough donors out there, this would be increasing that. But if it's we just don't have the ability to take the donors and they're just sitting around waiting for hours, and that's why we don't have enough, is it just a supply issue as far as personnel receiving the donations, storage? Where's our shortage coming from?
So
Ms. Nichols.
Thank you, Chairwoman. Excuse me. Yes, that's a complicated question, and there's a lot of factors around why we currently have a blood shortage. We saw an increase in demand nationwide. A lot of the weather-related incidents really caused a pinch on our blood supply. Additionally, with an increased demand, there's also, with all that weather, all blood drives are canceled. And we already have blood drives in place where it's in honor of a recipient, and that recipient gets blood donors to come out and donate in their honor, but it goes into the blood pool for all. So it goes to help all Idahoans, all people that need blood, and that those are a great way to increase the number of donations, but it's not going to help the overall pool if everybody is just coming in for one person, and besides compatibility and type of blood, what about all those donors that aren't the same type of blood? Wouldn't we want their blood to go into the general pool so that every person can have blood when it's available to them? Does that answer your question, Senator?
Yeah,
Senator Shipp.
Madam Chairman, thank you. Sort of. I guess the kind of what I was trying to get to was that it was implied that if we were to permit individuals to get their own donors, that it would decrease the supply, the general supply, which then it seems like that is implying it's taking away the resources to actually do the physical drawing of the blood, storing of the blood, et cetera. Is that the case, that there's just not enough personnel, storage? Like, why is it going to be decreasing the normal supply? And then I guess a follow-up question I think was asked, why couldn't that blood that isn't used then be recirculated if it's safe into the supply? Could that just be a policy change? Why wouldn't that policy change happen if that is just a policy change?
Ms. Nichols.
Thank you. It's not a policy that we are in charge of. We get it to the hospitals and then they do what they will with it. So I can't answer that, unfortunately. As far as it does not decrease or help the general blood supply, but it does take resources from the general blood supply, because somebody is either going to take a blood donation that goes into the general blood supply, or they're going to take a directed donation. And so that's where it's taking the resources away from the general supply.
Senator Lenny.
Thank you, Madam Chair. And it was Ms. Nichols, right? I was doing some digging around when this bill passed the House, because it obviously made a lot of headlines and whatnot. And I found that on the Red Cross Form 990, Red Cross made $3.2 billion last year, and 67% of that revenue comes from essentially selling blood to hospitals. And then the CEO of the Red Cross made a cool $694,000. So is this more about money? It seems like it's a money thing. Because if we pass this, I think the Red Cross would potentially start losing money.
Ms. Nichols.
So absolutely not. The American Red Cross is a nonprofit. And while we do operate on a cost recovery basis for our blood, because while the blood is donated, all the supplies and everything else that go into collecting the blood, including, the paid staff that we have, are are not free. So we operate on a cost recovery basis. As far as the salary of our CEO goes, I know that a lot of that is donated back towards mission of Red Cross. And the Red Cross, like I said, is a nonprofit, and the cost recovery allows us to operate in other fields like disaster relief and other areas which the Red Cross is currently alleviating human suffering in.
Senator Wintrow.
Thank you, Madam Chair, and Ms. Nichols, thank you for your testimony. So I have just a couple questions. When I'm making decisions about things, I'm thinking about, okay, is it safe? And then what are some of the larger implications here? So maybe talk a little bit about, I've read that there might be some risks regarding direct donations that maybe people aren't aware of. Maybe talk a little bit about the science here as far as, is one way safe or another? What does science tell us? Let's just start there.
Ms. Nichols.
Thank you. I am not a doctor, so let me start with that disclaimer. I do know that there are certain types of times when it's been testified when it is appropriate to do a directed donation. When somebody has an extremely rare blood type, when somebody has different antigens within their blood, then a directed donation is 100% should be done. As far as times when it is unsafe to do a directed donation, I know that there has been testimony regarding autologous donations, that autologous donations are not necessarily recommended by all doctors because they see an increase in infection, and they see an increase in problems with people that use autologous donations. As far as directed donations, there are issues, they brought it up briefly, between husband and wife donating to one another and then having a child. It can cause serious issues. Again, I'm not a doctor, but that's why we consult the doctors when making these decisions, and why a self-directed or a directed donation would be appropriate or not appropriate based on that medical knowledge.
Thank you, Madam Chair.
Follow up?
Another question. I appreciate that. Thank you. So it sounds like from your perspective, sorry, my phone is ringing and I didn't have it on silent. Let me get rid of that. It's distracting. So it sounds like through your testimony, really, the according to you, and I think for many people, the blood supply is safe. And so the concern is, if you detract from that safety right there, it might have a negative impact on donations overall and people's utilization of it. Is that correct?
Ms. Nichols.
Absolutely.
I'm going to wait for, I'll let some other people ask questions and I'll come back.
Senator Zeiderfeld.
Thank you, Madam Chair and Ms. Nichols. So can you tell me what the shelf life of blood is?
Ms. Nichols.
Thank you. It depends on the type of product that you have. So the longest is 45 days, and that's for red blood cells. For platelets, those have a much shorter shelf life. I believe it's 5 days. And it really depends on what the product is that you're using.
Follow up. So what kind of measures do you take to make sure that people aren't getting blood that maybe it has expired, or what happens to people that get expired blood? I just feel like there's a risk in everything that we do. And so, and also to follow up with that, how much blood do you dispose of because of the shelf life?
Ms. Nichols.
Thank you. I don't know exact numbers of blood that is disposed of. I do know that it is a lot of that is around education in the hospitals to make sure that if blood is getting closer to its expiration, then it's probably because it's in a rural hospital that doesn't have the volume, so it would maybe rotate out so that it would get used on time. We do not use expired blood. That would be an FDA real problem, and we do not use it if it's expired, period.
Senator Bierke.
Thank you, Madam Chair. And Ms. Nichols, thanks for being here, providing the testimony, and for the great work that the Red Cross does. We certainly appreciate that. My question has to do with what you said in your introduction, that you are regional, and there were 2 other states that you work within. Could you remind me what those are? I think one was Oregon, and the other one was?
It's
Ms. Nichols.
Thank you. It's East Oregon and Montana.
East Oregon and Montana.
Yeah, tiny sliver.
Follow up? My question is, we're dealing with something here for Idaho.
Correct.
What does Oregon do, and what does Montana do in this regard?
Ms. Nichols.
So, as stated, we do already have a process around both autologous and directed donations. So those processes are in place and they are in use, and we collect blood for them. When the order comes in, we fill it, and that's what we do in the other places.
Okay. Senator Renfro, very, very short, brief, please.
Thank you, Madam Chair. And Ms. Nichols, then, if you're already doing this, then I don't understand why this bill is actually needed.
Ms. Nichols.
I would agree, Senator. I don't think it is needed. That's my testimony, and my hope that that's what you guys will vote.
Okay, thank you. Thank you so much.
Thank you, Madam Chair.
Okay, next we have Laura Demaray. Please identify yourself, and then the time is yours.
Yes, ma'am. Thank you so much. I'm Laura Demaray from Cambridge. I support HB 528, and I share my own opinion. A few years ago, I began learning about direct donor blood when I had the need for a non-emergent surgery. Blood bank questionnaires at the time asked for COVID vaccine status, and I marked no. I was so naive in the process. When it was time for my own surgery, I asked to sign for blood, and I requested the non-COVID vaccinated blood pool, please, and it was not available. So I would not sign for my blood, for surgery, except for my own if it could be salvaged during a major abdominal surgery. It's not misinformation, but careful research and religious conviction that guide my assessment of DNA plasmids, synthetic pseudouridines, lipid nanoparticle biodistribution, ribosomal frame shifting, prions, amyloid-like fibrous clots, and persistent spike for over 700 days. I have no judgment of anyone regarding blood product choices. The bottom line for me was that there are products that I am not able to take because of my personal and strongly held religious belief. And a direct donor option enhances my chance for survival next surgery. If you call the National Blood Bank Special Collection Department, they say, no problem, it's here, it's available, you can do it. But over the last few years, several local friends have tried and encountered barrier after barrier, mostly administrative. It was not possible, and they all had to find other avenues, including other states, to receive direct donor blood, including a child. Though they may exist, I've not personally met anyone that has navigated the direct donor gauntlet in Idaho with success. The direct donor participants do not reduce or replace the current blood supply, but instead add to the blood supply with both donors that do not usually participate. And the unused blood can be utilized back into the general blood supply or aftermarket system, but that's up to the institution. Direct donor blood is not false security, but a peace of mind for the recipient, and they're tested just like everybody else, everyone else. I appreciate the valuable blood banks and healthcare providers, and I mean no disrespect to their life-saving services. I ask that you vote yes to HO 528 and codify the ethical, patient-centered medical choice of direct donor blood, an assurance to Idahoans that an important medical freedom will not be easily taken away.
Thank you, Ms.
Thank
Demery.
you.
Thank you. Any questions? Senator Bierke.
Thank you, Madam Chair. And Ms. Demery?
Yes, sir.
I've heard that testimony a couple of times, that we have kind of a block to doing this in Idaho. Can you give me a couple examples?
Yes, sir.
Ms. Demery.
Thank you. I'm still learning this process. Madam, through the chair, Senator Bierke. Yes, sir. For example, I had a friend who, she had a lot of issues with getting her own blood and her child's blood for a very important surgery. We finally found a hospital for it. However, we could not get the direct donor blood here. They actually went to Florida. And I have another couple colleagues here that will show you from their clinics. I've also tried to help in this situation, and it was such a gauntlet. We tried up in Lewiston, we tried here, we even considered other states, and it is such a gauntlet. It's like this administrative challenge where, and I don't know anybody that's made it through. And also, same with Montana. They too have tried this legislation as well. There are so many states, sir, like in Florida, that utilizes one blood, and they work beautifully with the community and do direct donor blood. And it's really up to the facility too to give it back or not. That's, yes, sir. So there's several cases, and more will come, sir.
Thank you.
Thank
Any
you.
more questions? Seeing none, thank you.
Thank you so much, Madam Chair.
Okay, next we have Leslie Manukian on video. Welcome to committee. Please state your name, and then the time is yours.
Yes, thank you, Madam Chair, members of the committee. My name is Leslie Manukian. I'm from District 26. I'm here in my individual capacity, but I'm also the president of Health Freedom Defense Fund, an organization, national organization that stands for health freedom for all Americans. And I'm so very surprised. This happened, the same thing happened in the House committee when I testified there, that there are organizations with vested interests arguing that this is difficult, that it's complicated, that it might be unsafe for someone, that it may not be what the doctors want. That's irrelevant. What is relevant is what the patient wants. Doctors work for us. These organizations are supposed to consult with us and give us advice so that we can make our own medical choices based on the best available information. They're not there to dictate to us. It doesn't matter whether it's difficult. It doesn't matter whether it's expensive. It doesn't matter if it's going to, be more onerous for them. What matters is that each and every one of us have the most basic human right to make our own medical choices free of coercion or bullying. This has to be respected. And it surprises me that so many people argue against this. I simply do not understand it unless it's because blood is big business, as one of the senators alluded to. In fact, it is my understanding that the vast majority of the blood that is actually donated in the state of Idaho is sold out of state. And is that why they're so committed to this? I don't really know, but the blood is not wasted. That's a straw man argument because these people wouldn't be donating otherwise. And I think that it's just important that we all recognize the most important thing, which is that each and every one of us gets the right to choose and direct our own medical treatment. That's it. That's what this should be about. No hospital, no blood donation system, or anyone should be depriving us of that basic right. Thank you so much.
Thank you. Questions? Senator Lenny.
Thank you, Madam Chair. Ms. Manukian, thank you for being here. So are you saying that in Idaho there is a problem with Idaho residents not having their medical wishes followed?
That's
Senator,
very, sorry,
Ms.
Madam Chair,
Manukian.
yes.
Go ahead.
Yes, Senator Lenny, this is a problem that's been ongoing since at least COVID, and possibly since before then. And I can speak personally in that when my own father-in-law was in the hospital in Twin Falls, he was unvaccinated during COVID, and they put a yellow star on his door in order to denote that he was not vaccinated, which is just so atrocious, it's hard to even imagine. But on top of that, what was worse was that we had full medical power of attorney, and the hospital refused to do what we requested. The hospital refused the treatments that we were asking for. And then when we asserted medical power of attorney, the hospital refused to actually respond to us any further. I mean, this has been going on. Let's not forget that 300 or 400 hospital workers in the state of Idaho were fired.
We're talking about House Bill 528.
This is what's going on
please.
here in this, unfortunately.
Thank you. we're on the subject of House Bill 528. That's what we are testifying on. Senator Lenny, could you keep your comments and your questions to House Bill 528, please?
Yeah, I was asking her, Madam Chair, thank you, if we've heard testimony in the room that said this isn't a problem, so I was asking her if she thinks it is, and I think what she was saying is completely relevant to this bill.
All right. Seeing no more questions. Thank you. Next, we have Michael Martinez. Mr. Martinez, welcome to committee. Please identify yourself, then the time is yours. Could you hear us?
All right. Can you hear me okay?
Yes, we can.
All right, great. Thank you. My name is Michael Martinez. Well, first of all, good afternoon, Madam Chair and members of the Senate Health and Welfare Committee. My name is Michael Martinez, the Executive Director of Vitalant in Idaho and Washington. As a nonprofit, Vitalant proudly operates blood donation centers in Coeur d'Alene and Lewiston. We serve 15 hospitals and have been an essential part of the Idaho healthcare community for decades. Blood donor and patient safety is our top priority. We share the Idaho Legislature's commitment to maintaining a safe, reliable, and accessible blood supply for all Idahoans. For this reason, we are concerned that House Bill 528, while well-intended, will unintentionally undermine that goal. Idahoans can already access directed or autologous donations when medically necessary. House Bill 528 seeks to fix a problem that doesn't exist. It will increase healthcare costs and may create unrealistic expectations among patients about the process and challenges of directed or autologous donations. Patients can already access directed or autologous donations currently. Vitalant and other blood centers already facilitate medically necessary directed and autologous donations, which comprise of less than 0.04% of blood transfusions each year. This is because the community blood supply is exceptionally safe and it meets the vast majority of patients' blood needs. There's simply no need for this bill. This bill does create a false sense of security that directed or autologous blood donation is safer. There's no evidence that directed donations are safer than the general blood supply, and some studies have shown higher infection rates. Directed donations carry an additional risk of reaction when the donor is a partner or relative. Furthermore, this bill may mislead Idahoans that there are guaranteed as directed or autologous donations. Just 62% of the population is eligible to give blood, so there's a significant chance that a patient's identified donors will not be eligible or not have the right blood type. If a patient wants to donate for themselves, which is an autologous donation before the procedure, perioperative donation increases the risks of anemia, which has been associated with increased morbidity due to donation and otherwise avoidable transfusion. It may be a patient's best interest not to proceed with autologous due to those increased risks. And finally, directed and autologous donations often go unused because they are set aside for a single patient, wasting resources to collect, process, and store blood and preventing it from being used by another patient in need.
Thank you, Mr. Martinez. Your time is up.
Okay.
Any questions? Senator Wintrow.
Thank you, Madam Chair. And Mr. Martinez, just really quickly, I think at the very end you were saying it could increase costs. Could you just tell me what you meant by that?
Sure, Senator Wintrow, thank you for the question. So basically, costs can increase depending on how many units, things like that, to about 2 to 4 times a unit from the community blood supply due to special scheduling, storage, and handling of that specific product.
All right. Seeing no more questions, thank you. Thank you for being with us today. Okay, next we have Amanda Cox. Welcome to committee. Please identify yourself and then the time is yours.
Thank you, Madam Chair.
My name is Amanda Cox. I'm here today representing myself as a concerned citizen and as well as the clinic director of a local family medicine practice. I would also like to take a moment right now to honor a patient, a young wife and mother of 2 boys who we lost just 4 days ago, who had to go out of state to seek care due to this very issue. She is one of 3 patients that I've attempted to assist with directed donations over the last few years. When I began seeking means for directed donation over 2 years ago, at that time the instructions and requirements were available on the Red Cross website. I did contact local donation centers and was told repeatedly that directed donations were not facilitated in Idaho. Fairly soon after that, the PDF with those specific instructions was removed from the website with only an email address to submit requests. To this date, I have never received a response to those submitted requests. In the case of any referral or provider order for any medical service, there's often additional documentation or specific information that must be included for the success of that order. Without that proper information, orders are often delayed or often denied due to those technicalities. Therefore, the instructions would be helpful. The focus for this discussion in previous hearings has been regarding the choice to make autologous donations. I agree that this process is a little more easily accessible within our healthcare system, although the limitations of this are why this bill is important. In an acute situation that would allow for a few weeks of preparation, I myself would be able to donate a pint of blood to be held for my procedure. But this bill would allow access for family and friends who are a match, who go through the process to do and receive the testing, to direct the blood to be stored for my procedure specifically. When time is limited, this option must be available to Idahoans. The process of connecting our community together in moments of need is critical for protecting medical freedom, encouraging our family and friends to seek timely medical care, and will only inspire greater participation in blood donation when there's a personal connection. I ask you today to vote in support of HB 528.
Okay, thank you. Questions? Senator Blaylock.
Thank you, Madam Chair. Just quickly, I just want to clarify because I know we had just heard that this is already in it's a federal law and that it can already happen here and that this isn't needed in the state. But your experience is that is not your experience. You've tried to request it, the PDF went away, then you got an email, you've never gotten a response, and so you personally have experienced this. Is that right?
Absolutely.
Ms. Cox.
Thank you, Madam Chair. Yes, thank you, Senator.
Thank you.
I personally have been one spending hours on the phone advocating for patients. Actually, the organization that Mr. Martinez represented was the closest that we received, was possibly sending a patient here in the Treasure Valley to Lewiston. But again, the obstacles were they needed a local doctor's order. It couldn't be a doctor from here. They were going to have to travel to Spokane for the actual transfusion. It's out of state. Our doctor doesn't have a license there. It was obstacle after obstacle after obstacle, leaving us nowhere. In addition, the cost for the patient just to have the donor give to them was upwards of $1,500 just to receive 1 pint of blood.
More questions? Seeing none. Thank you.
Thank you very much.
Okay, next we have Nicole Irwin. Welcome to committee. Please identify yourself and then the time is yours.
Thank you. Chairman Van Orden, members of the committee, my name is Nicole Irwin, and I'm the Regional CEO for American Red Cross of Idaho, Montana, and East Oregon, based in Boise. And many of my colleagues have said most of what I would want to testify on here today, but there's a couple clarifications. So as the regional director, I do not make the decisions on who is able to get a directed or autologous donation. That is done by a physician and hospitals, so I have never seen one of those come by my desk, nor would I want to, nor would I ever see that. Another piece that you guys talked about was vaccinated blood and being able to tell if blood donations are from someone who is vaccinated. If you remember last year, we were here talking about this bill. A test does not exist for that. There is currently not a test, nor do we know that one is in existence that would be able to identify if someone's blood was from someone who has had the COVID vaccine. And I just want to say I'm really glad we're talking about blood donations. We do have shortages, so anything we can do to raise awareness for this, and I really would just encourage you, with only 3% of Americans who are eligible do donate blood. So I encourage you to talk to your constituents about this, donate blood yourself, know when there's a blood drive around you. We do over 3,000 of those across the state, and we collect about 195,000 units. So thank you for your time today. I'm happy to answer any questions.
Thank you. Any questions? Seeing none, thank you. Thank you for being with us. Okay, committee, we've only got a couple more. Hang in there. John Tribble. Welcome to committee. The time is yours. Please identify yourself.
Thank you, Madam Chair. My name is John Tribble. I'm a medical doctor. I'm an emergency physician up at Weiser Memorial Hospital. I'm the physician advisor for the Southwest Health District here in Southwest Idaho, and I am the medical director for a local family practice urgent care clinic. And I'd just like to reiterate, as another person testifying, that we have had difficulty and have been unable to provide directed donations to my patients. Ultimately, this bill is about, what I think is about patient-physician autonomy, and this is a pillar of Western medicine, an ethical right that we have, and these decisions that are being made should be between a patient and that doctor. If that doctor decides that that is what's best and right for this patient, we shouldn't have government interfering with that. We should not have corporations interfering with that. And I will go on to say that, here in southern Idaho, we basically have a monopoly by the Red Cross, this corporation. There is not anybody else to go to in Southwest Idaho. So as we have tried to get patients to go through this process, which is federally regulated and already in law, we have not been successful. We have run into barrier after barrier and with no legitimate medical reason. I'd like to point out and highlight an inconsistency in what I'm hearing in the arguments from the other side. They're telling you that this bill isn't needed because we can already do this. But at the same time, they're telling you that it's going to be too costly, it's going to erode trust, it's going to be too difficult, it's going to cause problems, it might be unsafe. Well, which is it? You can't have it both ways. You can either do it and it's safe and it's being done, or you can't. And right now you can't in Idaho, and it needs to change. So thank you for your time. I appreciate it.
Thank you. Questions? Seeing none, thank you. Thank you for being with us. Okay, one more. We have Barbara Jordan. Welcome to committee. Please identify yourself, and then the time is yours.
Thank you so much, Madam Chairman and members of the committee. My name is Barbara Jordan, and I'm here representing the Idaho Trial Lawyers Association, and I don't normally get to come to health and welfare, so I appreciate the opportunity to be here. And my apologies, I grabbed the wrong folder when I left this morning, so I'm using my phone, and I kind of feel like a teenager. So, glasses on. We don't really have any concern at all about the bill and about the issue of folks donating their own blood. We do have a concern about the immunity provision that is in the bill and down in Section 4, which gives providers immunity for gross negligence, and so limiting it to gross negligence instead of negligence in general. So we would, if we could, ask the committee to, and I hate to slow the bill down, but we would like to make the bill a better bill by just taking a couple words out and adding some language in there. Here's our concern. People come and they have, if this passes, or apparently you can now do this, but if you do donate your own blood or you have people, you plan ahead under this provision and the provider somehow accidentally destroys your blood or mismatches it or something, you do not have a legal recourse under this statute. So we are a little bit concerned about that it does, if you do have the right to make that advance and a forethought, that you do not have a recourse if something accidentally happens to your donation. So under this, it requires an intentionality, and that's our concern.
Okay, thank you. Any questions? Seeing none, thank you. Thank you for being with us. Okay, committee, that's all we have to sign up today. Senator Nichols or Representative Bruce, would you like to close?
Yes, ma'am. Sorry. I do appreciate that. And thank you for everybody who spoke. I'd just like to mention a couple of things. We've heard the process of what it is to get blood here. I think it's already legally federally, but we have had folks that have had to leave the state to do it. This doesn't change anything with federal law. It doesn't. I know they mentioned COVID or safe blood or not safe. I'm not saying any of that. I'm not trying to identify that one blood is safer and one is not. All I'm saying is that we should codify this into Idaho law to say the same thing that federal law does. I will address what she said about the gross negligence. When I spoke with the lawyers of the bill, we had the language written as it is. They wanted to leave it like that. I also spoke with the hospitals. They stayed neutral on it. So I would like to keep it the way it is. I know that she does have, she did bring up that point, but I think this also protects folks, moving forward. So as I close, the patient can still be denied for all the same reasons. The cost is passed on to the patient. It is federally legal, and we are having serious problems for folks trying to donate their own blood here in Idaho. So thank you.
Senator Shippey.
Thank you, Madam Chair. For a motion?
Do we have any more questions for any of our Senator Nichols, would you like to give some closing comments?
Thank you, Madam Chair. I just want to be brief here, but I just wanted to say that this had a personal component to it. I've had a child that's been going through treatment over the last couple of years, and we inquired about this, and the hospital told us it would be such a hassle to try to do it that there just really wasn't any point in doing that, and that really frustrated me as a mother and concerned me also as a mother and as a senator that this is happening in our state. And this is something that's been used for years and years. I mean, the 70s, 80s, 90s, they were doing direct donations like this forever. So this really doesn't change anything. We're just giving people options. This is about choice and people putting stuff into their bodies on what they're comfortable with. And so nothing's changing in any other way, shape, or form. And so I would just ask that you send this to the floor with a due pass recommendation. Thank you.
Thank you. Senator Shippey.
Thank you, Madam Chair. I move to send House Bill 528 to the floor with a due pass recommendation.
Moved by Senator Shippey, seconded by Senator Kaiser to send House Bill 528 to the floor with a due pass recommendation. Do we have more discussion? Senator Wintrow.
Thank you, Madam Chair. Just briefly, I'm probably the minority in the committee, I guess, but I think my overall concern about the bill is that, one, I think what we've heard here is that it casts doubts on the safety of the blood supply, and it has a potential to set up two separate systems potentially. When I think about the mission of the Red Cross and the blood supply, it's very community-oriented, and I mean, I've been in a serious accident where I was in the hospital, and all I cared about, did it match my blood type? And there is a history potentially of this kind of fear getting a little bit out of control and irrational that would impact safety of the community, especially in a disaster. So I don't see any, if we're already doing it, I'm not sure why we would put it in code, but, and we've heard from the Red Cross, but I'm really kind of concerned that we're setting up kind of the separate but equal kind of system, who can pay for it and who can't.
Senator Shippey, would you like to speak to your motion?
Yes, thank you, Madam Chair. Yeah, I'll just keep this as brief as I can. Just a couple of things. Number one, it was stated that this would cause us a further shortage in blood donations, which is apparently happening right now. And it wasn't demonstrated to me in any way that it was an administrative cause for that shortage as far as personnel and so forth, but it seems to be that the shortage is donors themselves, which would bring more donors into the pool. So it seems like that it actually increases the amount of donors there. And I don't see anything in the legislation that would increase danger or risk. And if there is any, and this is a patient asking for this to be done for themselves, and so this is a choice that they are making. I haven't heard anything that would convince me that this is unsafe in any way. I don't see that in the bill. We were told that the legislation was not necessary because it's already happening, but why the opposition to the legislation if this is just codifying what's already being practiced? And so it seems like the legislation will be doing something and will be giving greater patient choice there. So definitely supportive of this, and I appreciate the bill sponsor for bringing it, and hope you all can support it as well. Thank you, Madam Chair.
Senator Zeiderfeld.
Thank you, Madam Chair. Just for a little comment and testimony of my own. So back in 1999, right when we were getting to go ready to have Y2K, supposedly, my son went in for an appendicitis surgery. And through some complications, they wanted to give him a blood transfusion. And I wanted to give directly to him because I know my health. I know as a mother, you just want to do what is best for your child. And so I asked if I can give directly, and they said no. And then they were trying to continue to tell me that he was a hemophiliac, which he wasn't a hemophiliac going into surgery. And so luckily, they gave the option to give him vitamin K, so we didn't have to do the blood transfusion. But I think it has nothing to do with, causing more harm to anybody else. But if we have the ability to give directly because we want to do that as loving parents, and I'm not saying that other parents aren't loving, but if we want that option, I think that should be available to us. And I also want to, ask, what did they do in the past? So now that son of mine, he went through the military. He was a cavalry scout, was out there in the field. They actually did direct transfers of blood on the field in the military. And so there is that ability to do it. It's not going to take away, it's going to add to. It's going to just, to me, it's going to make everything better if we have more options to do this. And so I will be a yes vote.
Senator Kaiser.
Thank you, Madam Chair. Yeah, and just a reminder, again, it's already federally permitted. But 10 weeks ago in December, my wife had a scheduled major surgery and with a few months in advance notice and wanted to do a direct donation with her mom, and we were denied. So it's shocking to hear anyone say that doesn't occur, it never happens. We've heard testimony today that happened to us directly as well, much more recently. So I too will be supporting this legislation.
Senator Bierke.
Madam Chair, thank you. A lot of comments already made. I'll just simply say that I remember this kind of discussion we had last year over a similar issue, over a bill very similar to this. This one is kind of pared down, and I think it's a great paring down for the time we're in. My comment is more about the corporatization of medical care in general and how we exert our rights for medical freedom. I just need to, maybe admonish all of us that as that pendulum swings back, with Dr. Tribble, I mean, we want to point the finger where the finger needs to be pointed, but remember, we want to get back to medical days of yore and regain our freedoms and stop this corporatization of medicine in its tracks. We need to also respect the institutions and respect the doctors that are working with us and remember that as well. And I'm for this legislation.
Thank you. Senator Lenny, did you have a comment? Any more? Okay, committee, we have before us a motion and a second to send House Bill 528 to the floor to do pass. All those in favor, say aye. Aye. Any opposed? Okay, would you like to be recorded? Okay, thank you. Okay, committee, we do have a meeting tomorrow, so we will see you tomorrow. We're adjourned.